Welcome to CDP's podcast, Practical for Your Practice,
where we give you actionable intel to support what you do, one colleague to another.
Hello, everybody, and welcome to another episode of Practical for Your Practice. I'm Dr. Kevin Holloway, one of your hosts today, and I'm joined by my fantastic co-host, Dr. Corinne Lefkowitz. Hi, Corinne.
Hello. How are you today?
I am hanging in there. I'm feeling a little spicy, so we'll see how this goes today.
I love spicy, Kevin. Okay.
Well, and it's spicy for reasons not related to anything we're going to talk about today. So I'm going to try to mellow the spicy. But
I would think not, because we have one of our favorite guests, one of our favorite colleagues on the show, and our number one fan.
While this guest has not been a guest on the podcast yet as a guest, our listeners may recognize that this is I think, president of the podcast fan club. I think this is how she described herself before. And voracious consumer of the podcast, if I understand it right. And seriously, one of the most awesome people and dearest and sweetest people that we work with, Dr. Erin Frick. Erin, welcome to the podcast.
Hi, thank you so much for having me. And now I feel like I have so much to live up to.
We've built you up now. Everybody's expectations are so
You
high.
have to be nice. So yes, you have to work hard at being nice and sweet in this podcast.
Right. And I just want Kevin to be increasingly spicy, which is going to be counter my introduction. I'll do my best.
I hope I didn't constrain you by calling you sweet and nice. And
no, I will
Dr.
be me.
Frick is also brilliant. She is also so productive. She's wonderful. So she's across the board.
Don't add more pressure, Kevin.
Okay, how about then we just let you introduce yourself versus us introducing you as nice and sweet.
Yeah. So I'm Erin Frick. I'm a licensed clinical psychologist. It's wild that I was doing the mental calculation just last week of how long have I been in the mental health field. I have been in this field for 29 years.
Oh, wow.
Isn't that wild? That is, you all are determining how old I am right now.
I was going to say, and you don't look a day over 21. So great job.
Corinne, you're my favorite always. I've done work in community mental health is where I got my start, and a lot of time spent in university counseling centers. And then in 2010, I spent most of my time in the Midwest, and I got a big urge to want to go somewhere different and do something different. And so I made a huge life-changing decision, and I went out to California and did some work at Travis Air Force Base in the outpatient mental health clinic there, and absolutely fell in love in working within the military community, and just knew that this was how I wanted to spend the rest of my career. So I've been with CDP for 12 years now, and I'm now an associate director for the last 5 years. I work under the amazing Kevin Holloway, who's part of this podcast, leading
this
a couple
of different... This is how we got you on. It's I could just say, Erin's going to do the podcast.
Right. You will do the podcast. No, not at all. You are two of my favorite people, Jenna, as well. And so I'm happy to be here.
Thank goodness you threw her name in, because she'll listen to the episode and then she'll be angry that her name wasn't mentioned. Her ego is very fragile. So
we wouldn't want that. Absolutely.
Then you think Spicy Kevin is a thing? Just
Spicy Kevin. I think that's your new nickname now.
Maybe Spicy Jenna.
Yeah, and about 7 years ago, the center was really developing a wider range of suicide prevention trainings and needing more trainers. And so I spun up to become a SP trainer at that time. So I'm excited to be here and talking with you all. So,
and in addition to that, one of the programs that Erin is the associate director over that she leads is working with the Safeguard Initiative with the VA, which is working on, I'm going to totally short shrift this, but working on training providers in the public who see veterans, particularly certain groups of veterans that might be at higher risk for suicide, in suicide prevention skills. So Erin's not just, she read a couple of articles and now she's a suicide prevention expert. Like, you've really dug into this, and this has become something that you really are expert at.
Yeah, it's something that I think we all kind of see the value and the growing need for across the mental health community and space. But yeah, in the VA Safeguard Project, it's a wonderful initiative by the VA recognizing that not all veterans get care through the VA system. And so wanting to make sure that community programs are really set up and prepared to address the needs of all veterans. And so that's wonderful to know that that's an important initiative that's happening.
So true. So let me see if I can make this transition. I'm not sure how I've
Yeah.
formed it in my head yet, but when we started talking about doing this episode, I think one of the things that we were kind of kicking around is like you do a fair amount of training, like a lot of training in CBT for suicide prevention. You do some consultation for CBT for suicide prevention, a lot of suicide related work. And one of the things about this podcast is that we really want to make, kind of the dissemination accessible, right? Like learning in a workshop is important first step. We're usually talking about the textbook perfect clients, right, as we're learning the skills. But then we have to apply those to real life situations. And so as we were kicking around, like, what are some of those real life situations that come up frequently, or whether it's in your own practice and those you consult with? Like, what are some of the challenges that come up when working with folks in a suicide prevention context? And I think one that we landed on is so it resonates with me a lot. And I think it will resonate with a lot of the folks that are listening. Just, the folks that we're often working with who are dealing with a suicide crisis, it's not it doesn't feel like it's very focused work all the time because they are usually in crisis in so many parts of their life,
Mhm,
almost like crisis
mhm,
of the day when they're coming in. So how do we stay focused on kind of a phased model of suicide prevention in this kind of protocoled approach when there's so many challenges to that focus? So just throwing that
mm.
out there. Wonder what thoughts you've had to get us started, or maybe kind of laying the foundation of what does that look like?
Yeah. Great lead in, by the way. I think that this comes up in multiple ways potentially. I mean, I certainly think there is, the example that we've all kind of had of what do we call it? The doorknob moment where,
Mm,
you've
mhm.
had a session with someone and, you're at the point where you're really winding down and heading out the door and they get to the door and then they say, "Oh, and by the way, you
Right.
know, this really important thing happened, that I'm struggling with." So there's certainly those kind of moments. But I think, like you mentioned, when we're working in a suicide prevention context, there are likely to be some of those folks who are just navigating difficulties, challenges, overwhelm in their day-to-day life. And so they may be coming to us not only because of a suicidal crisis or maybe a suicide attempt even, but because they're facing crises day after day after day
Right.
in their life. And I think the first thing that goes through my mind when I think about that is um, how difficult it is to move through the world when that is your experience of life. So it's
Mhm.
it's very much kind of a heart-centered type of feeling, of just the heaviness of a client feeling that way.
I think about that in that uh, I am not a suicide prevention expert by any means, but I've certainly learned some things here and there and attended a lot of workshops you've trained on, Erin, as well. It reminds me, just in the context of, let's say, interpersonal theory of suicide, right? The idea that the components that are contributing to someone's suicide crisis is that hopelessness and perceived burdensomeness. Like, man, like to be in that situation, I imagine is like this huge soup of crises across many
Right.
domains, and this perception that, there's not a way out and you're burdening all those that you love. Like, that's a lot to deal with when we're
Yeah.
focusing.
Absolutely, and one of the things Kevin Hines is his name, he is, an amazing figure within the suicide prevention area, and he talks about it from his own experiences of a suicide attempt, um, uh, off of the Golden Gate Bridge, and so he's a very well-known
Mm,
speaker and, really does a lot of advocacy around suicide prevention. And one of the things he describes as he tells his story was he had all of these difficulties going on in his life, and he was on the bus to get out to the Golden Gate Bridge area, and he talks about how, like, he was so in despair, and he just wanted someone to ask him if he was okay. And
Mm.
he just had this array of crises running through his mind, and I think about that oftentimes when I'm meeting with someone of, like, what are all the things that are going on in their mind that they're not saying
Yeah.
because maybe they don't know if they can or they should or if anyone will care, um, that people are carrying a lot more than we realize, even when they come into therapy,
Yeah.
is my belief.
That's uh, that's a really good story. It moved me, that Kevin Hines story. I'm gonna have to go and read more of his material.
Uh-huh.
Very moving, and I got sort of the visual of somebody, like, kinda grasping at straws, like, so many
Mhm.
things happening at once without having any more information than what you just said. I'm just imagining somebody grasping at straws, and that notion of wanting support, and I'm extrapolating here and sort of imagining what, this person's entire life, who I only just learned about a minute ago. But, related to that, wanting support and also imagining that if people are dealing with this many crises at one time, they may have also lost support from
Yeah.
people close
Uh,
to them because they've kind of worn people down or burned them out, etc., pushed them away in somehow. So I just sort of imagining how those two things go together and also what that might feel like then when you're working with that patient as the provider.
Yeah. Well, and to your point, Corinne, a lot of times it can be that of, this may be someone who has said no to, going and grabbing coffee,
Mhm.
because of all of the distress and stuff that
Yeah.
they're going through. So they may have, in many ways, burnt bridges just out of their own feelings of isolation and
Yeah.
struggle. But it can
Unintentionally, completely. Yeah.
Exactly. But it can also be very much within the own person. So
Mm.
within one's own mind, the person might believe that they are a burden to others and
Mhm.
that, they can't or shouldn't ask for more from people
huh,
because it's
yeah.
not appropriate or it
Yeah.
would be, hard on the other person. And so both within the relationship and within the person, there can be a lot of things that serve as kind of like blocks or barriers to getting that kind of connection that is really needed in those moments.
It occurs to me that can impact the therapeutic relationship then
Right.
too. Like you alluded to this earlier, that there may be a lot more going on for our in fact, probably is a lot more going on for any one of our clients that are coming in the office door than just the thing that they've identified for us to work on. I mean, how many times have we heard from clients, like, I wasn't ready to share that yet, or,
Yeah.
there's this other thing going on, but I didn't think you wanted to hear about it, or like, or we never hear about, right? That
Yeah.
they never bring it up. And I even think about myself, like I mentioned probably several episodes ago that I'm trying to eat my own dog food, if you will, right? I'm going to my own individual therapy, and every time I go in, I'm thinking like, well, okay, what things can we talk about? What things do I not talk about? Because I don't want to fill up the session with things that are irrelevant or whatever. I imagine our clients go through that literally every time they come in there. And if you have this additional piece where you're perceiving you're a burden on other people, maybe you've already burned a lot
Mhm.
of those bridges, like you also either are trying to prevent that from happening with your own therapist or
Yeah.
still feel like you're
Mhm.
just not allowed to do that in this therapeutic relationship where it is like the most ultimately appropriate place to do that, right?
Right?
Yeah.
I think that's an excellent point. I mean, again, when we think about doing some of this work with people who are in these crisis moments and in a lot of distress, there's just so much going on. And we're talking right now about what's going on for them, but the reality is we are also agents within
Yes.
that
Mhm.
relationship. And so
Mhm.
we're bringing all of the stuff that we have going on into those connections and into those conversations as well, which I think then just doubles, what's present in the room with us.
Yeah. It's
Yeah.
like, well, what are some of those challenges, would you say?
I mean, I think in terms of are you talking about in terms of, like, the therapist part of that
Yeah.
or
Like
both?
what
Yeah.
Yeah.
what baggage we're bringing into the room, for example.
Probably a lot of baggage
You
is my guess.
specifically.
I'm
Yeah.
specifically talking about me. Um, no, I mean, I think especially when I think back to some of my really heavy clinical workload times, Um, one of the things that I described, I think, to folks at times is there was a point in my career where I was doing so much clinical work, and a lot of it was with really high risk folks that I literally felt like there was a conveyor belt that just went
Mm.
from my office to the front door and
Yeah.
then back to my office. And it was just like I was, opening the door, jumping on the conveyor belt, going out to the front,
Yep.
welcoming someone, bringing them back to my office over and over and over again. And in that experience of things, I found myself maybe getting a bit desensitized to the work of, feeling like it was such routine and um, kind of like, session by session type of work that I felt like I was starting to maybe not really appreciate the humanness of what was happening
Mm.
Yeah.
and the
Yeah.
importance of the crises. Like, I remember a specific moment where, I'm not proud of this, but, I had brought someone back to my office. It was a very long day, and I remember that they were conveying things that let me know that they were experiencing some suicidal thoughts that had been elevating. And I remember my first reaction was frustration.
Mhm.
And, I'm a very humanistic centered person in terms of how I operate as well as CBT, and I remember feeling disappointed in myself that frustration was the first feeling I had,
Yeah.
and that was a signal to me that, okay, I need to refocus myself. I need to take a look at, my workload and what's happening here because this isn't how I wanna show up for my
Mhm.
clients.
But so relatable, right? Like, how many of us have felt that frustration at times with any of our clients, but and then feel guilty for it, right? But you're right, like, we're working in a context that isn't not by design, but, isn't always just naturally supportive of that work too, and yeah,
Well,
that
and when you're working with somebody who has expressed thoughts or even actions about suicide, that the pressure is on.
yeah,
And, for me, thinking about some patients who I work with, in those moments, you feel like the weight of the world is on your shoulders as the therapist. Like, you need to assess this person. You need to figure out what they need right now. You need to get them to safety. You need to figure out how to write a safety plan that's going to keep them alive or, get them into a safe environment. The pressure is on at that
yeah,
moment. And
yeah,
I'm thinking
Mm,
about that in the context of having maybe one or two people in that category per day. When I think about specializing in this kind of work or having more frequent clients with those needs, it is exhausting and depleting, and I think many of us are not okay with are not a don't allow ourselves to acknowledge that, to admit, "Oh,
yeah,
I have a limit to what I can do," or, "This is really hard work, and I might not be able to do all of it all the time."
and
yeah.
and on top of that too, like, that pressure you describe, I know for me at least, the times where I've worked with somebody who is, expressing suicidal ideation or maybe is in a suicidal crisis, I'm feeling some fear.
Yeah.
Like, I'm feeling fear like, what if I can't do all the right things that's going to prevent this
Mhm.
person from dying by suicide? Number one, thinking somehow it's all like
Right.
I'm that powerful. But then also like anticipating, we've all heard stories about, so-called psychological autopsies after
Mhm.
a suicide and worried about feeling blamed. Was there something I could have done different? Blaming ourselves. Is there something I could,
Mm.
and all this is going in my head before the person has done something extremely dangerous, but it's,
Yeah,
it's all part of that mixture of pressure.
Mhm.
yeah, it's definitely there with us during this process. If we're aware of the context of all of those things, then yeah, it's certainly there with us. And I think a lot of that can contribute to some of the burnout that goes along with people who really specialize in this area. I also think, the folks who are doing this work are incredible human
Mhm.
beings,
Yes.
because again, to really meet people when they are at their most difficult point, which, I think we could all fight over, which mental health concerns are the most difficult points. But certainly, I think, folks who are experiencing suicidal thoughts and behaviors are on the list somewhere there.
Yeah,
That takes special people to do that work and to do it
for sure.
well, and, um, and doing it in the context of all the additional stuff that we might be carrying, it just adds to, the courage and yeah, kind of the privilege that I
Mm.
think you can feel by, doing that work and having people really, come to you in those moments.
As we're talking about this, in some ways, it kind of clarifies in my head something I've thought about before too, that there may be some of us as providers who tend to avoid,
Mhm.
if we can, working with folks with suicidal ideation or suicidal crises, and not. I'm trying to carefully say this because I don't want it to sound like I'm blaming those folks who do
Yeah.
feel that pressure. I feel it, or the folks that maybe feel frustrated or like, man, I'm so glad other people are good at this because this isn't my thing, right?
Yeah.
Um, because this is part of that normal human response too, but it certainly makes sense why this could be hard work that maybe somebody feels like they get their kudos elsewhere, right? Like, I'm a PE therapist. I love doing PE. I love seeing people improve with PTSD as they're taking their life back. And not that the progress is always linear, but like I can at least kind of see places where they're kind of moving forward. They're starting to take some life back. There's been some progress here, even if the little progress is a little bit, and I can anticipate more. My experience when working with folks with suicidal crises or ideation too has been that it's not always linear, right? Like,
Mhm.
I sometimes feel like, okay, wait, we had a great session and things are moving forward, and then the next session it's like, and now we're going to the ER, and then I feel like, oh gosh, maybe I didn't do this very well. But it also occurs to me that's kind of the nature of the work, right? And
Yeah.
as humans, that feels weird. We're not maybe effectuating change the way we might anticipate it, but not that that makes the work less important. That's
Yeah.
the careful line I'm trying to walk here, but
Mhm. Yeah, I mean, if you think about it, and this is true for all of our clients in many respects, but I think especially around suicide prevention, knowing that so much of what's happening in people's lives are stressors popping up that, may or may not be expected to show up in life and how those things can be triggers for a suicidal crisis. It does feel, certainly, I think a bit delicate in doing this work of like what's the flow of the work week by week, day by day. And just because someone was doing well when you saw them one day does not mean that when they show up the next time that they will just be continuing along
Mhm.
that line of progress. So that nonlinear aspect of things, I think for me has really resulted in kind of redefining what a win or a success looks like.
yes.
um and that to me goes way back in my earliest part of my training. I trained in community mental health, and in working with particularly groups of people who often are lacking a lot of resources and may not have had the best early life experiences. You're measuring wins in very small increments. Like I'm talking like millimeters, right? Like, did
Mhm.
someone make their appointment today? Were they able to
Right.
find transportation or, do what they needed to do to get to the appointment? And that was a huge win for folks sometimes in community mental health. And I've applied that same kind of thinking when it comes to work with individuals at risk related to suicide of really looking for the small wins and reflecting those things back to folks as a way of building some hope and some belief that improvement is possible. It just may not look like today, I did all the things on my to-do list and therefore I am getting better. It might look like I got out of bed after just hitting the snooze one time instead of five,
Mhm.
and really kind of redefining what that looks like.
That framework is so helpful to remember. I mean, I feel like I know it intellectually in my mind, but it's very easy to move away from that kind of framework. And especially again, if you're not consistently doing this type of work like I am not, I can imagine applying that framework more easily, I guess. Like let's say I'm doing insomnia treatment. Okay, I want people to have linear progress, but if they don't, all that means is that they slept a fewer hours last week than they did, you know,
Yeah.
the week before. Like it's not great, but it's okay. It feels like there's such higher stakes when it comes to working with folks who are struggling with suicide. Um, but all the more reason why we need to kind of reorient to that framework and recognize, I don't even want to call them small wins, just recognize that they're all wins, I guess.
Yeah, yeah. And maybe helping
Yeah.
the client feel that too, because my guess is when they're, at risk for suicide, nothing feels like a win, or it's
Mhm.
easy to
Mhm.
write it off as not that important, or, you know, kind of having that negative bias and interpreting everything going on in their life.
Mhm.
Yeah. Definitely. I think an added part of that that for me becomes really important, and I think, I just listened to the last podcast episode earlier today, and so I wanna, make a little plug for that because it was an incredibly done, podcast where both Corinne and another one of our coworkers talked a bit of, suicide within personal experiences as well. I don't think everyone has to be a therapist that does suicide prevention work. Like, I mean, I certainly think there are valid reasons why people may, kinda opt out of doing that work. Um, at the same time, the demand for mental health services in general continues to grow, and the number of newly trained clinicians entering the field is not matching that. And so
Mhm.
Right.
for the folks who are able and open to doing suicide prevention work, like we really need people who are out there and really building the skills and getting the training and doing that work, because it's not for everyone. So it's important that we keep building and growing the volume of people who can address this really important need.
Well, if I can jump in, first of all, thank you for the plug, and I think you're referring to our episode, "The Club That Nobody Wants to Be a Part of," or what was the exact
Yes.
title, Kevin?
That was it. The club nobody wants to join, coping with suicide loss. It's episode 3 of this season. So by the time this episode airs, it'll be a couple of episodes
It'll be a
before
few
this.
episodes,
So,
but
but
yeah. But
yeah,
thank you for the plug, and I will say in that episode, I talked about the fact that given my personal history with suicide, I have opted to not work consistently in the suicide prevention subfield because it's just not something that I think I can handle. Um, but I also don't have the luxury of not being educated and skilled
Yeah.
in this because no matter what I do, no matter what I choose to work with, no matter who I see, all mental health conditions, concerns, and many physical conditions all bring a higher risk of suicide. So
yeah.
I don't
Yeah.
have the luxury of just not knowing about it. And I guess I kind of want to expand on what you said, Erin. We do have a need for people who are willing to do this work, but we also just have to accept that all of us need to be
Mm,
able and
and
willing
Yep.
to do the
Yep.
work.
Yeah.
yeah. I think such an important point that you make there. Yeah, because one of the things we talk about in the suicide prevention trainings that we do is how suicide is transdiagnostic, right?
Hmm.
There's not a diagnosis in any version of the DSM that says suicide is its own condition. It's embedded within many conditions. It's part of depression. It can be part of anxiety. It can be part of PTSD, insomnia, chronic pain. Like there's just so many points of connectedness with what might be behind someone developing suicidal thoughts and behaviors. That, as you mentioned, it's not something that any of us in our field can totally and completely avoid. It's something we have to be aware of and able to manage at some level.
So here's my question for you. I mean, not, I, I feel like most of what I've said makes it sound like our biggest concern is how the therapists are handling this and managing it. And of course, that's not the primary concern. The primary concern is, the health and well-being of our clients and making sure they're doing okay. And we can't help them get there if we're not okay too, right?
Mm,
Like we talk about self-care a lot in very dismissive terms at the end of
Hmm.
workshops and don't spend a lot of time on it. And I'm not necessarily asking a self-care question here exactly, but given all that, given, some of the complexity of challenges and pressures and that, and even, maybe even some of our own personal experiences that come to bear as well, what can we do? Like, number one, maybe there's two parts to this question. How do we help our clients manage the crisis of the day, or the revolving door, or the
Conveyor belt.
conveyor belt, thing
Mhm.
from their side? How do we help them do that? And what can we do for ourselves to help manage this
Yeah.
as well, so that we can be the best at what we're doing to help these folks? Whether that's, a focused practice with folks that have suicide risk, or as Corinne was saying, we're going to encounter that sometime in the work that we do. How can we help ourselves in those situations?
Yeah. So, it's a great question, and it's definitely not a one size fits all
Yeah.
approach. Not shocking because most of what we do is not a one size fits all approach. Um, but in terms of managing this with clients, I think one of the overarching things for me is having those conversations directly with our clients of, you know, there's going to be times as we're meeting where crises are going to continue to happen. Stuff's going to, occur in between our sessions. And I want us to talk about how we're going to handle that together. Like, yes, we are, let's say we're doing cognitive behavioral therapy for suicide prevention to address a recent suicide attempt. That is our plan for how we're doing therapy. And additional crises are likely to still happen in the context of that work. So I think it's important to have those conversations on the front end so that clients know that it's okay to bring those up. They don't have to feel like they need to hold them inside because
Yeah.
they've committed to doing this EBP, right? So I want them to know, first of all, that it's okay to voice those and that we have a plan for how we're going to work on them together. Um, I think the other part of that is kind of that notion of flexibility, that it's not a one size fits all approach. So
Yeah.
in a recent training, I was peeking in on some, role plays and such that were happening in conversations, and I heard something that was a little bit alarming because I've heard this stuff in the past, but it's kind of one of those things that you hope that as suicide prevention grows and becomes more widespread, that maybe we are dealing with some of the myths and things and getting those out of our system. But I heard a therapist saying, just because your client says that they have suicidal thoughts doesn't mean that they will try to take their own life. And I that belief is out there still. It's out there not only by therapists and folks in the medical field, but it's out there in our civilian world as well. And so
Ah,
one thing about that is I think we have to take the things that people say or do seriously.
right.
Hopefully, that means they won't ever attempt suicide or die by suicide, but I think we still have to take that seriously and, you know, have a plan for we're going to talk about crises when they're occurring, even when we're doing an EBP. And that might mean that at the beginning of a session, we may take 10 minutes to talk over a crisis that occurred during the course of the week, and then jump back into and apply what we know from CBTSP to that crisis. So it doesn't have to stop the work. It just maybe gets integrated into the work.
Grist for the mill.
Um, yeah, exactly.
I love what you're saying there, because it occurs to me, and maybe this is a metaphor you use a lot too, but I think about, like, let's talk about like heart attacks. If somebody is reporting chest pain, and they're
Yeah,
reporting maybe some of the other things, like maybe it's radiating pain, right? It's on the left side. They are short of breath, nausea, like
right.
all those things. It it may be a heart attack, but it can be lots of other things, right?
Yeah,
Lots of other not lethal things, lots of other less scary things. But you don't go, it's probably not a heart attack. Like,
right.
right? We would, or, in the vast majority of these cases, it turns out not to be a heart attack, so you'll probably be fine. Like, we're taking them to the ER. Like, that's
Mm,
what we're doing, because this is a very serious, it potentially could be very serious. And if you took them to the ER and it turns out they didn't go to the ER, so what? But if they
right.
needed to go to the ER and you didn't take them, that
Mhm.
that mistake is way worse. So, like, the
Yeah,
right answer always is to take somebody to the ER and get them checked out. And if it turns out that it wasn't a big deal, great. That's
yeah,
good news. That's a good problem to have. And similarly, when our clients are reporting suicidal ideation, particularly if they're mentioning having a plan or intention, or like we have some of those concerning warning signs, they're coming up, the right answer is to address that, not to blow it
Yeah.
off, even if it is a low base rate event.
Mhm.
Mhm. Yeah.
Yeah, 100%. I mean, in those moments, I think, that's great if they don't act. Like,
Yes.
if someone is voicing distress, and even if they're voicing it over and over and over again, but they're not acting, to me, that's great. Let's talk about the voicing of the distress. Let's talk about any pattern that is surfacing when we meet, the distress that just continues to pop up in that person's life. So that becomes part of the conversation, not a reason to kind of dismiss any potential risk moving forward. Um, so yeah,
And telling the
totally
client
agree.
that too, right? Like, it's not a
Yeah,
Mhm.
bad thing to bring this up. Like,
yeah,
I'm glad you
it's
brought it
I'm
up. Thank
glad
you
you
for
brought it.
sharing it
Yes,
with me.
yeah,
exactly.
yeah, because in many respects, to your point about that, the fact that someone might be experiencing life with these recurrent distressors, and just things that are really difficult in their life is probably incredibly important for us to know in the midst of doing suicide prevention work.
Yeah,
So we would not want to discourage them from bringing that forward. Um, that leads me to thinking about the managing these things for ourselves. I think one of the most important things is developing very strong crisis intervention skills. We are not predictors of suicide. We are, at least at this point in the field of suicidology, we don't have the ability to predict who is having suicidal thoughts, who will move forward in a suicide attempt, and those who will not. We have the ability to know some of those warning signs and risk factors that might contribute to the movement from thinking about to acting upon suicidal thoughts, but we can't predict that with accuracy at this point. And so
yeah,
we use those crisis intervention skills as the way of inserting protection and space and time when people are in distress, so that they may be having thoughts, but they have mechanisms to reach out for support, to
yeah,
reach out for emergency care, to use their own coping skills to be able to keep themselves safe in the midst of those suicidal thoughts. So that's a very important part of things with people. And I think luckily we're in a space in our field now where crisis intervention trainings and skills are integrated into most suicide prevention training, and so they're more easily accessible than when I was starting out, and we had a whole lot still to learn about how we support people who are having suicidal thoughts and behaviors. So I would say one thing we need to do is we need to really have excellent crisis intervention skills.
yeah,
So for sure, training has gotten better and our knowledge has gotten better in terms of what we know about suicide and frankly what we don't know about suicide.
Yeah.
But I would argue one thing that has not gotten better is our focus on how do we take care of ourselves? How do therapists
Yeah.
manage their own all of these anxieties, worries, and pressures that we've talked about on this podcast? So, Erin, I'm sure you're going to solve that problem for us now. How do how do we take care of ourselves?
You know that's what I do, Corinne. I solve massive unsolvable problems. Um, I don't have the solution, not surprisingly. I know what has worked for me, so I will be happy to share
Please.
what that looks like for me. Um, Several years ago, I don't even, it was in the early 90s, whenever that was. I was introduced to, I think that was called stress management at the time. Um, but it was some of the work by John Kabat-Zinn around
Mhm.
mindfulness and kind of some other folks at that time. And for me, that has become a really important part of my own wellness. Um, it's allowed me to be aware of difficult emotions like that frustration when that client voiced suicidal thinking that was escalating. And then to notice that that was happening inside of me so that I wasn't just responding from a place of
Mm.
frustration. I could, kind of table that and work on it later of like, well, okay, why was I so frustrated? That person was just sharing something really difficult. Why was I experiencing what I was experiencing? So it allows me the ability to both be aware of the emotions that are surfacing in difficult situations, but to also then be able to deal with those maybe at a different time
Yeah.
than in that therapeutic moment. Um, Similarly, I think staying tuned into my body's responses when I'm clinically, when I'm in kind of an intense situation, like working with a suicidal patient, noticing my breathing, noticing how my body is feeling tense or relaxed is an important part of for me, really being with the client and being as open and present as I can be through that awareness. And I think it's also then helpful outside of the therapeutic session of noticing if I've had heavy caseloads, or if a lot's
Yeah.
going on that, maybe I need some more time for myself. Maybe I need, some time. Maybe I need to take a vacation, right? Maybe
Mhm.
I need a little bit of time to process things or to journal, or it helps a lot with my awareness for sure.
It strikes me a lot of the same things we would recommend to clients who are,
Yeah.
struggling with stress. Or like
Right.
we can take our own advice and maybe need to be better at that.
Yeah, absolutely. I mean, I think there's a lot of parallel here, really. I mean, again, we are not immune from life crises. And so by virtue of that, I think we have to learn those skills of coping for ourselves, and they become some of the same things that we help our clients build up and utilize as they're navigating suicidal thoughts and experiences as well.
Erin, you may know that our theme, if you will, for this episode or for this season is to focus on impactful moments. And we've been talking this whole episode about working with tough situations and all the reasons why somebody might not work in this type of setting. Curious to hear, are there any moments that have impacted you, that have gotten you to the place where you are, that have stuck with you and influenced you as a suicide prevention expert?
Yeah. I actually, when, thinking about the impactful moment, because I knew it was coming, I had multiple things kinda popping through my mind and kinda kept going back and forth of what to talk about, and I think where I settled back in on was, I think my experiences, early on in life actually have served me very well in doing this work. So, I grew up in somewhat of a chaotic environment, I would say. My parents were quite young when they had, my brother and they were dealing with a lot. I mean, they were very young people trying to find their way as a young family and, trying to navigate life. Um, and while there were times, when our home was really overwhelming as a kid, it also really made me someone who kind of leaned into difficult moments and
Huh.
difficult emotions,
Mm.
and even times of crisis where, I find now, and I think sometimes my husband maybe is a bit irritated by it, but when there's crisis or chaos, maybe a house full of kids, my daughter is 8, and so as she and her friends are making the loudest noise you could ever imagine, I oftentimes feel a sense of calm and a
Mm.
sense of clarity and a sense of control of things, um, which I think came from my childhood. And I think in therapy, it has helped me to really be able to zoom in. And yes, there's chaos, there's concern, there's stress, there's stuff in the room with us. But I almost feel like a sense of like a connectedness to someone that almost has a visual quality, like strings that are coming from me to that person in a way
Interesting.
that
Mm.
allows me to draw closer to them when they're in crisis even. That may sound strange, but I feel like that came because of my growing up experiences and how I learned to navigate that, and it feels to me like a natural, really wonderful way to kinda bring some challenges into, my professional life.
I gotta say that really resonated with me, and I'm imagining that actually resonated with a lot of listeners
Yeah. Yeah.
as well. I don't know why we are, moths to a flame when it comes to chaos, but some of us are just like that.
I was about to ask if you could package that and sell it, but it sounds like it was also very hard earned. It's not as easy as that.
I think we can cultivate it. It doesn't always
Yes.
probably have to come through, difficult experiences that may have just made it happen earlier or something. But yeah, I mean, I think a lot of therapists, they learn that through their experiences or just by really developing a caring, compassionate stance toward their clients.
So that I think is a great maybe segue into thinking about, like at the end of every episode, we like to leave with actionable intel. So kind of what are those things that a listener can apply to their life right now, like or whether it's, working on a skill or a resource or something like that.
Incoming actionable intel.
So, I mean, so far, it sounds like one of the things is we need to focus a little bit on self-care, right? Like we need to give
Mhm.
ourselves some grace. What are some of the other, pieces of actionable intel you would leave with our listeners today?
Yeah. So, the door handle, thing that we talked about,
Yes.
earlier on, I read an article and if I can find, who it was by, I will be happy to share it with you. It was actually focused on nursing, but, I love it because I think it applies therapeutically, to our work in, the field of psychology as well. Um, the notion was applying that mindfulness thinking process to every time you grab a door handle to go into a patient room was kind of that notion of like really kind of practicing when you grab that door handle, like you're opening the door to a new encounter with the beginner's mind, with not, without preconceived notions of what's on the other side of that door. And I think about my conveyor belt experience now and think about that from that sense of, you know, I hope what I brought most days to that work was when I opened the door, to the patient waiting room and brought a new person back to my office, that I hope it was more of a reset. Like I was opening the door and I was resetting myself for a new space with a new client that I was meeting there. So that would be one thing of take that brief moment to kind of reset yourself, whether it's, you know, getting a drink of water, whether it's, doing a quick walk around your clinic, or whether it's just being really aware when you grab that door handle to enter into the waiting room and bring back a new patient, that can be a moment of reset as
Yeah,
well.
I love that. And you mentioned the article. We'll put the link to the article,
I'll see
or
if I can find it. Yeah.
if we can find it, yeah, in the show
Yeah.
notes, so y'all can read that too.
Yeah. Two other things came to mind.
Okay.
I definitely would recommend that folks find some mechanism for that self-care. For me,
Yeah.
it was mindfulness. Like that's something that I've integrated into my life to this day. And I don't practice every day, but it's there. It's a skill that I've built and I can lean on it as I need to. It might not be mindfulness for other folks. It might be exercise, or it might be, talking to close friends, or a variety of things. But just make sure you have a thing, whatever that is, that can be your outlet and your centering, because doing this work is really tough sometimes.
Yeah. Yeah.
So that would be another thing. And then the last thing I would say is there are great resources out there through the Suicide Prevention Resource Center. But one tool in particular, I feel like helped me to really start to navigate some of the suicidal crises in a clearer way. It's through the VA, and they may have changed the name, the Therapeutic Risk Management Tool, which we can definitely include as well. And we teach this in the CBT for suicide prevention training that we do. It helps to be able to ensure that depending on the different crises that are showing up for people and their background and their current experiences, it helps us to ensure that our decision making for how we respond to those crises is in alignment with the standard of care. And that to me, clinically, to almost feel like I had a mentor in my pocket, right? That, I'm seeing these things about the person. And now I've got a tool to be able to kind of compare what I'm seeing and what kind of level of care might be needed or recommended.
Yeah.
Just it's an added layer of consultation when you need it on the fly. So that's a tool that I would highly recommend folks become expert in.
I love that. And again, we'll try to put links in the show notes so you all can find that and
Yeah.
become expert in it. If I may, I mean, one other I think that we mentioned and I think is worth kind of walking away with to think about too is, maybe review how do you define a win, right?
Mm,
And think
yeah.
about, are there ways to define a win or progress that um, really kind of helps you to move forward in this work anyway?
Mm-hmm.
I mean, certainly if a win means that our clients are cured after one session and they never have a crisis again because now all
Yeah.
of a sudden they have all these tools and they're at peace constantly 24/7, that's unrealistic. And
Yeah.
of course, I don't think anybody's doing that. That was just to try to illustrate it. But maybe just kind of sit with yourself and maybe it's a journal prompt to think
Yeah.
about what is a win in this work, and maybe kind of recalibrate that a little bit to help us to see that improvement, to see those wins where they
Mm-hmm.
happen. It can help with the motivation to stay engaged.
Could not agree more. I think that's incredibly important, especially in a time where, there's a lot happening in the world around us. There's a lot that people are going through in life. And I think sometimes in those moments we have to capture the wins, maybe in a smaller level so that it again builds our hope as well as that for our clients too.
Yeah,
Thank you so much, Erin, for being here.
that
Thank
was so
you.
awesome.
Thank you to our listeners. Always a
Yes.
pleasure to be on this episode.
We'd love to hear from you as well. So we'd love to hear about your impactful moments, or if you've got questions for any of our past guests, or if you have ideas for topics or future guests, please reach out to us. We've got an email address we'll put in the show notes. You can leave us a voicemail on our Speak Pipe. We'll leave the link for that in our show notes as well. Again, we'd love to hear from you and what it is that you're interested in. And until then,
Stay curious.
and mind your EBPs.
Bye,
Thanks, everybody.
Bye.
Be sure to subscribe to Practical for Your Practice to be notified when new episodes arrive. Our theme music is Failed Attempts by Nitro, and our administrative assistant is Bree Mercer. This podcast is produced by CDP at the Uniformed Services University of the Health Sciences. The views expressed are those of the speakers and do not necessarily reflect the opinions of the Uniformed Services University, the Department of War, or the U.S. government. In addition, references to any specific companies, products, processes, or services does not necessarily constitute or imply endorsement by the Uniformed Services University, the Department of War, or the U.S. government.